So I won't talk too much because this is all about the work and the science. And I will, I think our president too should be here though. So let me get him to speak a few words. Professor Etuk, AFEMSN president. AFEMSN is the Association of Fetal Maternal Medicine Specialists of Nigeria, as I'm sure you know. And we have been having these educational webinars quarterly so as to educate and continue to communicate about fetal maternal medicine in Nigeria. We're a subsidiary of Sogon. Professor Etuk, Dr. Adaramoye, can you please unmute Professor Etuk if he's on so that he can say a few words to start us off and then we can continue. Please unmute Professor Etuk. Dr. Adaramoye, can you hear me and have you done so?
Yes, I have.
Okay. Prof, sir, please, can you unmute and just give a few words so that we can start? Thank you.
Thank you very much. And good evening, everybody. The VP1, the speaker, and everybody, we're excited to be here today. As part of what we usually do as FMC, to educate ourselves and educate the people around us. And today's topic is very topical, very important, and very great for all practicing obstetricians. Labor care guide, the new generation pathograph. We have been talking about the use of pathograph right from the days of old, and everybody is very familiar with it. A new one coming. It looks as if it's impossible to disengage yourself from the pathograph. But as it is, by the time we listen to this expert, you will know the difference. So you know that labor care guide is the way forward. I remember not long ago, late last year, we gathered at a outskirts of Abuja to make modifications, make it to be adopted to fit the environment, the Nigerian environment. I'm sure the document, by the grace of God, will soon be out. So I would wish we all listen and get used to what is going to happen and what we are going to use. And I know that with time, the pathograph we are using currently will soon become obsolete. So I welcome everybody. I know the speaker. He has never disappointed me. Today cannot be an exception. He's an expert. He knows how to play with words. So I welcome everybody and welcome the speaker, my executive, my ESCO members and all AFEMSN members. And again, let me use this chance to say that AFEMSN is the way to go. Join, you'll never regret. Thank you very much. I hope I was
yes,
audible.
you are, sir. It's just this thing. Okay, so Professor Olayemi, over to you, please. Please start the presentation on simplifying the WHO guidelines. Thank you very much.
Thank you very much, everybody. And I stand on the existing protocol set by my president and my VP1 for the AFEMSN. Good evening, my colleagues and senior, some teachers, and maybe other ladies and gentlemen. So today we'll be talking about simplifying the WHO guidelines. And so I'll be attempting to simplify the guidelines. I hope I succeed. I pray I succeed. Now, there are two guidelines we'll be talking about. The first is the recommendation itself, which is the one that gave birth to the guideline. The recommendations are that for a positive pregnancy experience in labor for the women, and is part of the implementation efforts for these recommendations that finally produced the labor work guide, which we'll be talking about too. But permit me, as I start, to first lay the foundation, go back to the original document, the mother, and then from the mother we'll go to the baby, which is the guideline. So as regarding conflict of interest and full disclosure, I need to say that I was a member of the guideline development group of these documents. And I also have some affiliations with WHO, but I don't work for them and I haven't been paid to make this presentation. I also have to acknowledge my colleague, Dr. Moasim Bello, who has given me access to the slides. He's made a presentation that is similar to this, not the same focus, but similar in some parts. And I've been able to get some inspiration, some confidence by looking at the slides. So, the majority of women that deliver worldwide occur and they pose low risk to both mother and babies. However, the time of birth has been shown to be critical survival of women and their babies, and the risk of morbidity and mortality will increase considerably if complications arise. More than 1/3 of maternal deaths, half of stillbirths, and a quarter of neonatal deaths result during this time. And most of this death, as we already know, occur in low resource setting like ours. So, monitoring of labor and childbirth and earlier identification and treatment of complications are critical for preventing adverse birth outcomes. Improving quality of care around the time of birth has been identified as the most impactful strategy when compared with both antenatal and postnatal strategies. And then it is also a target for this SDG 3 to have healthy mothers, well-being for all ages, and children with women and adolescents. So this is really a very important aspect of health. And that is why the WHO had to produce the guideline, and that they are hoping that it will meet these objectives. So I'll start with, like I said earlier, with the interpartum guide, interpartum care, recommendations for interpartum care for a positive childbirth experience. And I'll start with the definition of positive childbirth experience. I've highlighted some things deliberately. Women want a positive childbirth experience that fulfills or exceeds their prior personal and socio-cultural beliefs and expectations. And then they want to have a healthy baby in a clinically, psychologically safe environment with continuity of practical and emotional support from birth companions and kind and technically competent clinical staff. Most women want a physiological labor and birth and a sense of personal achievement and a control through involvement in decision-making, even when medical interventions are needed or wanted. This is the basis on which the questions, the research questions, the guideline questions were posed. And these are the recommendations, these are the targets of the recommendations. So the center of this document are the women, their expectations, the need to have a clinically and psychologically safe environment for delivery, companionship, and then shared decision-making. These are all aspects that will be covered in this presentation. The scope of this guideline focuses on healthy pregnant women. And the recommendations are targeted at them. And it is useful for all women. However, when there are complications, there are other guidelines, and that's where our own local protocol comes in. So the women that's going to be, the guidelines going to be used for are supposed to be healthy. But if there's any problem or if there are complications, we should use other guidelines and other protocols in addition to these recommendations, to this guideline that we're using here. So they're not supposed to be, we're not supposed to exclude any woman from it. However, it's targeted at healthy women, hoping to keep them healthy while they're in labor. But if there are any issues, we need to refer to other guidelines or other protocols, which I'll be discussing later when we're talking about implementation. So the target of the audience for the recommendations, what is the target audience for that document? It's everybody here. I've looked at the list, and we're all either public policy makers, implementers, healthcare facility managers, non-governmental organizations, professional societies like AFEMSIN, so on, and then down to nurses, doctors, general practitioners, obstetricians, which covers, I think, everybody that is here eventually, ultimately. So in looking at the guideline, the WHO uses the framework of care, quality of care for mother and newborn health. Now, what this says essentially is that these recommendations will not work unless the framework is in place, unless we have a strong health system, unless we provide, we have the structure, our processes are sound, process of provision of care, evidence-based practice, which is the foundation of this guideline, actionable information system, functional referral system, effective communications, respect and preservation of dignity, emotional support. Those are the two aspects of provision of care and experience of care. And of course, we can't do this without competent healthcare workers, essential resources, and we need to keep monitoring ourselves with the outcomes, coverage of key practices, people-centered outcome, and the health outcomes that we're familiar with, maternal mortality, perinatal mortality rate, all these rates are important in all the in this framework. And we need to think like this when we're using the guideline and when we're in giving health to mothers. A closer model is the one that we're supposed to use in taking care of mothers in the interpartum care. And again, respectful care is there, emotional support, effective communication, pain relief, regular monitoring and documentation, which document is supposed to facilitate, oral fluid intakes, mobility in labor, adequate referral system, and continuity of care. All of this are covered in the recommendations I'll be discussing soon. How was this guideline developed? Well, the WHO has a handbook of guideline development, and we can refer to this. But the summary here is that they create priority questions and outcomes. I'll be showing some of the questions that was created for this guideline. They retrieve the evidence. These are done by internally, usually in the WHO, and then external people come in and assess and synthesize the evidence. They formulate the recommendations and the plan for dissemination, implementation, impact, and updating the guideline. All this are included in this guideline we're going to be discussing. So, how do they grade the recommendations? What are the characteristics of these recommendations? They use the grade and evidence to decision-making framework. So it's not just the efficacy of the evidence, the intervention effect as showed here. Their values will be considered, the values of how this intervention affect the values of the women will be considered. The resources available to implement this will be considered. The equity that this implementation will provide equity for everybody, acceptability and feasibility. These are important criteria in making the recommendations. I will highlight a few of the priority questions. Oh, I'm trying to, sorry. Okay. Oh, okay. When I was practicing this, I was able to zoom. Okay. So, well, if you look at the part I actually highlighted, the women in labor, continue labor support, companionship. So the population the question was addressing was the women in labor. The intervention was companionship in labor, continuous companionship in labor. The comparator was usual practice, and the outcomes are listed in the next column, and those include mode of birth, perinatal and vaginal trauma, duration of labor, augmentation of labor, use of pain relief, maternal health, and so on and so forth. So the other question that is very relevant is what appropriate definitions of first stage, latent phase, and active phase? This is very important because one of the paradigms that this guideline challenges is our usual paradigm that everybody should dilate at 1 cm per hour. I'm going to provide evidence. I'm going to show the evidence that are supporting that this may not be what we should be doing, and so on and so forth. There are many questions that I can't really zoom, so I will have been able to show more. Again, there are questions on mobility. That's another major paradigm shift in this document. Women should be mobile in labor, and they should not just sit in one place and supine. In fact, this document presumes that being supine is actually an abnormality. When we're dealing with the labor guide, I'll be highlighting this. So let's go to the categories of recommendations. How are they? What categories of recommendations do we have? This document contains 56 recommendations. 26 of them are new, and 20 of these recommendations are integrated from other guidelines. So when the evidence is convincing and the other things like value, resources, equity conditions are met, this and then it cut across all divide in terms of the low or high income countries, is this category is indicated as being recommended and should be implemented across board. The same way, when the evidence supports the contrary, that this intervention is going to be harmful or will not provide equity or is not going to add the value of the women, or that women find it's not within the range of their value system, this recommendation is not recommended. The ones that stay in the middle are those recommended in specific contexts. So it's only applicable to certain conditions. Sometimes it could be equipment, sometimes it could be the cultural setting of the women, but these are the ones that are recommended only in specific contexts. And finally, there's those that are recommended in the context of rigorous research. These are the ones that usually maybe most of the evidence come from a particular region and not from the other region. So WHO will want the other region to also do research in their own setting to make sure that the findings are consistent and the intervention can be recommended. So concerning the integration of other recommendations, only the recent recommendations are only recent guidelines, which was published. At the time this was published was 2018. So only recommendations published from 2012 upward were considered and integrated into this guideline. So I will start with the recommendations that are across board. Care throughout pregnancy. It is expected that women will receive respectful maternity care towards pregnancy. This is recommended. Effective communication between the care providers and the women are encouraged during labor, and this is recommended throughout the period of labor and birth. Companionship is also recommended, and continuity of care is only context specific in its recommendation, because like we know, there are many models of antenatal care, of labor and delivery in many countries. So it's only the one in which you're able to accommodate this, where the same women will see the women at the antenatal clinic and the same women will see them in labor. So the women are familiar with the member of staff. I'm sure, I don't know of any center in Nigeria that is able to afford that. Not my center anyway. So maybe we need to do more research or we need to look at our context. So I'll be taking companionship because we need to understand the evidence that supports companionship. This is a concurrent review by Boren and Hofmeier, and they looked at 26 trials, 15,000 women or 16,000 women. The trials were done across both low income and high income countries, including Nigeria and South Africa, and they found that the continuous support during labor improves certain parameters. Spontaneous vaginal birth compared to cesarean section. Instrumental vaginal delivery were reduced. Analgesia were reduced. Regional anesthesia were reduced. And this cuts across board. The only limitation they have to this study is that they haven't looked at the more long-term outcomes like postpartum depression, difficulty in mothering, and all that. So, but based on the evidence and the strength of the evidence, and also looking at the quantitative evidence from qualitative evidence for quantitative studies, the values, women from both high income and low income countries value non-pharmacological pain relief measures, which companions are able to provide. Is one of the outcomes that is positive. The cost effectiveness, even though it's not been done in low middle income countries, is found to be very cost effective in America, where people have to be able to pay for their companions in dollars. I think they pay upward of about $900 for companionship. Despite that, the people that have companions on the whole spend less than those who don't have, because by the time you look at all the instrumental vaginal delivery, cost for instrumental vaginal delivery, cost for cesarean sections, all of this make it even more expensive than having companionship. And then looking at equity, they actually looked at women from IDP camps And when these women come for labor and they have companions, they feel good. They don't feel like outsiders from the communities they come from. So this is a very good way of actually providing equity in labor. So looking at all the evidence, this is why it is recommended. Now, the other things we'll be looking at are the other thing I'll be providing evidence for, because this is part of I'm laying a foundation. The labor guide contains a part on supportive care. And we have to understand the evidence for this supportive care so that we can imbibe it. We know that the evidences are strong and we can actually have confidence in using in relying on the evidence. Progress of labor, there are many things that we used to have before that are not recommended. As I am believing that the cervical rate is 1 cent per hour during active phase of labor is not recommended. Maximum cervical dilatation of 1 cent per hour throughout for alone should not be used as an indicator for obstetric intervention. So using it as for intervention is also recommended. And then natural labor may not accelerate until about 5 cm. So we're establishing with evidence, it's established that the new active phase of labor should actually start at 5 cm. This is what is right. So assuming that you can labor will not accelerate until cervical dilation is 5 cm is not recommended. So all this old beliefs that we have, well, they are not. Let me just put it this way: there are new evidences that support that this old belief should be discarded, and we should imbibe the new evidence for cervical dilatation. So I will go to the evidences for cervical dilatation. A study done shows that cervical dilation is actually a poor diagnostic accuracy, is poor in making diagnostic accuracy. What does that mean? When you are trying to look for things to predict whether there will be bad outcome or not, cervical dilation has not been proven to be a very good way of looking at this. And there are a lot of issues. There are about 3 or 4 studies that I'm showing here. The sensitivity specificity, I'll be showing that later on other sites. And then the commentary about it, about photograph, challenging the design, the evidence which led to the photograph. So all of this are things that came up and were discussed during the production of the new guideline. So here is one of the most compelling evidences. If you look at sensitivity, this is for, if you look below, we're talking about adverse fetal outcome. Fresh stillbirth is A. For Apgar cause less than asphyxia is B. There here is asphyxia, and then C is for birth asphyxia. Sorry, the low Apgar score is for B, and C is actually for birth asphyxia. Now, it looks good if you look at the scatter, but when you come to the overall, you see that both this is not just that specificity is hovering around 50%, but both sensitivity and specificity are hovering around 50% for all of them, which means you might as well toss a coin in predicting whether, rather than use the photograph to predict these outcomes. So that, I mean, these are from large trials, bringing studies together. If you look at individual studies, you may want to think, okay, maybe it's working. But when you pull out all the data, it's looking like photograph is not really discriminatory in terms of these outcomes. And if you look at this, this is also apparent here. Most of the studies showed sensitivity, specificity hovering around. By the time we find the average, it's about 50%. So this, for those who have crossed the alert line and for those who haven't crossed the alert line, the instance of adverse birth outcome is also very low when you look at the larger studies. For one of the studies, just about 2.3% for those who cross the alert line. This could be by chance alone. So all these evidences are put together. And more importantly, all these are put together and is showing that crossing the alert line, using the alert and active line, an action line may not, actually the action alert line will not be a good predictor of outcome in terms of interpretum care. So what do we do? Challenging the progression of labor by 1 cm2, as is evidence are provided now. We assume that everybody dilates from 1 cm per hour, especially from 4 cm. These are studies that have shown that there's such a wide range variation. As much as 5 hours can elapse within that one to dilate from 5 to 6 centimeters. And this does not lead to adverse outcomes. So these women who are slow dilators in quotes are not actually, don't have more worse outcome than those who have been allowed to go at the 1 cm per hour. So these are evidences that are important. This are also evidence from other studies showing the mean time for dilation from one level of diastolic dilation to the next level, 2 cm to 3 cm, 4 cm to 5 cm. So all of these are in hours in terms of the time. But looking at the 95% confidence interval, it's such a wide range, and all this end up with normal delivery. So these are important factors to consider, and these are evidences to suggest that we need to change our thinking concerning these evidences. And what are the qualitative evidences in favor of dilatation, of rejecting the 1 cm per hour dilatation? What that matters to women, even though women want shorter labor, but when they were interviewed after the labor, for those who went with the flu, they preferred the fact that the labor was not, interventions were not put in place to hasten labor for them. So in terms of the acceptability, women actually accept staying in labor within this range of greater than 1 cm per hour dilatation. And then there was no evidence of value and equity, which is area of research that we can embark upon to see whether whether these things are within the value of women, or whether there's equity in allowing this women to go through labor at this rate. So I have provided the background for the real work we'll be doing, the real document to be talking about. So introducing the labor ward guide, which is the one that is actually the new thing that is coming up mostly. Now, when I first heard about the labor ward guide, I was really afraid. I was wondering that we cannot cope with pathograph. Looking at the evidence for pathograph, which Dr. Marcin Bello presented quite elusively in his presentation, there's low utilization of pathograph. Now we're bringing something higher. It's similar to the SDG Millennium Development Goal saga, where something was produced, but apparently the thinking of the United Nations and most world leaders now is that there shouldn't be a divide between low-income countries and high-income countries. The same standard should be across board, which is why these things are being introduced. So what is the labor ward guide? The principal aim of the document is to monitor and document well-being of women and the progress in labor. It's supposed to guide skilled health personnel to offer supportive care throughout labor, assist skilled health personnel to promptly identify emerging complications, prevent unnecessary use of interventions in labor, and support audit and quality improvement of labor management. So, summary. For whom should the labor care guide be used? All women in labor. I mentioned that early. High-risk women may require additional monitoring and care, but all women in labor should have this guide used for them. Women who have entered the active phase of labor, which is now defined as 5 cm, is when it should be initiated. So it should be initiated at 5 cm. And then where should it be used? It is designed to be used at all levels of care in health facilities. That is one of the implementation issues we'll be discussing later on. So how do we use the guide? There are 4 principles in using this guide: assess, record, check reference value, and plan. In the past, we're using the alert and the action line as references. Now there are individualized references for each of the recorded observations, and we'll be going through that soon. Just to show the evolution of pathograph, the pathograph went from being a document with latent phase. We are now at the level where our alert and action line, where there are no latent phase. And finally, from there, we're moving to the labor care guide, which has 7 sections, just like the pathograph. It was modeled after the pathograph to make it easy to use. There's section 1 to section 7, and I'll be going through this section and how recordings should be made in each of the sections. So each of the sections have specific aims and goals and purpose. The first section, like in all of this labor document, is identifying the woman and the characteristics for admission. The second part is supportive care. The third part is care of the newborn. The fourth part, care of the woman, labor progress. The fifth part, medications and shared decision-making sections. So the first part, the name of the woman is supposed to be there. Well, maybe I should just go straight to the examples. So this is a woman here. Okay, so Mary Jane is written below. She's 38, even though not written, but that is implied. And then these are fourth pregnancy. So I need to mention this too. The way parity is written, this document allows us. I'm happy that
we have a hacker, and the thing is getting worse. All these lines on the.
It's not for me. Maybe I should stop and start again.
Yes, please. Stop sharing and start again, please. And let's hope that helps. And everybody should please identify themselves. Everybody, otherwise I'll take you off. So SM56. Okay, if I don't see your name, I'm going to take you off, please. Because there's somebody hacking, and that's why we have all these squigglies here.
Stop share. Okay.
Thank you.
Okay. So let me start again. Okay, I am at, let me just go to So sorry for the delay and for starting again. So this is the I mentioned this, I think I've passed this level. We're here. So we're talking about the identification of the woman using the example. So the name of the woman, parity. I was trying to explain parity. Like most of the documents, you are allowed to use the way it's written in your own environment. This woman in our environment will have been gravida 5 para 2 plus 2. But in this document, it's written as para 2. But of course, we'll write in the way we understand. The history of stillbirth and anemia is written here, and the dates. More importantly, well, not more importantly, also important is that the fact that she has ruptured her membrane at the time she has ruptured her membrane is also allowed to be put in the section 1 of this document. Now, if the time is unknown, you will put the AU will put there instead of a figure, which is what the table I didn't go through initially was contained. Okay, it's here. So if the rupture membrane date or time is unknown, you put U. This is part B. Let me just hold on. Let me talk about the time. Just like the pantograph, there are figures in hours which speak about the time in hours. Each of this of these figures refer to time in hours. Then the actual time is written in the column in the column above to indicate the time. Now, in this particular woman, she achieved full dilatation and she was moved to second stage. Another unique aspect of this document is that it has monitoring for second stage, which pantograph does not have. So these are the these are the peculiarities of this document and an advancement over the pantograph. So there's a section where we're talking about how to complete that section in a few minutes as we go on. Now, unlike the pantograph where alert is a line, alert in this document is a column. Maybe I should go to the first one and before we sorry. Yes. Unfortunately, I cannot. Oh, I've done it again. Okay. So the alert line, the alert column is excuse me. The alert column is just as listed in alert column, and all the normal parameters or reasons for alert are written along the column. So as you are filling the document, you just refer to the alert column and see whether okay, right. So this is alert column. Yeah, so the alert column is here. So for instance, for companionship, not having a companionship is an alert. Yes is a normal. Pain relief, to not get to pain relief is abnormal. So you put N, when you put N there, it's an alert. And you have to go to the section below and actually assess here and have a plan concerning that. So this has been dealt with. Section B, which is about companionship pain relief. The ligand there is yes or no, and the alert is as written. So this is the same Mary Jane. She receives a general clinical assessment and has been attended to labor ward because she's over 5 cm dilated. She's monitored by the midwife on duty. She's not accompanied by relation or someone from her social network. She reports feeling, this is at 6 a.m. She reports feeling insignificant pain due to uterine contractions and requests pain relief. She drank fruit juice and is walking around. Then the midwife offered her a companion of her choice, and she chose her sister, and she was invited and instructed, while the nurse goes to another area to offer care to other women. And then finally, in the last section at 7 a.m., she's lying in bed and she's been drinking water. Now, if you look at that in terms of what is normal and abnormal, at 6 a.m., she didn't have a companion, so that was abnormal, and that was written as no. Later, the sister was with her as yes. The same thing with pain relief. She was over pain relief at about 7 a.m., and that's okay. But more also looking at the lower segment, at the lower part of the lower column, she was mobile. That was considered to be normal. But when she now slept on the bed, this was considered to be abnormal and an alert, and something had to be done about that. So mobility is encouraged in labor. Now, like I said, concerning integrated documents, the evidence for oral intake during labor and for mobility during labor is obtained from this other WHO guideline. And what that says is this, basically, that looking at people that took water or food in labor, there are no significant difference in the operative delivery, no difference in section, no difference in epidural rate, no difference in having to give IV fluids or oxytocin augmentation. So essentially, it's saying that both taking allowing oral fluids in labor is not detrimental to the woman. And then concerning mobility, there was another concurrent review. This was updated actually. The initial review was inconclusive, but later on it was updated. And now there's a clear evidence that important. Let me highlight that. Authors conclude there's clear and important evidence that working an upright position in first stage of labor reduces duration of labor, risk of the section, the need for epidural anesthesia, and does not seem to be associated with increased intervention and negative effects on mother and baby's well-being. So these are important evidences that we have to show that mobility is actually encouraged in labor. So concerning the care of the baby, this is very similar to what we used to do before. The alert for baseline heart rate is 110 to 160. Late deceleration is considered the abnormality here, and then meconium or blood up to 3 pluses. Having a fetal position of being posterior or transverse is considered normal. Caput of 3+ and above, and molding of 3+ and more is considered to be an alert that needs to be flagged. These are the ligands. If there are no deceleration, it's N. If there's any deceleration or late deceleration, variable decelerations. These are all the way this is put. Let me go to the example to illustrate this better. Okay. So this is our Mary Jane again. At 6 p.m., fetal heart rate was 160 beats per minute. The fetal position was posterior. Amniotic fluid is clear. Fetal heart rate that's at 6. At 6:30, note that fetal heart rate is, you'll see from the document, fetal heart rate is done every 30 minutes, unlike the other parameters. So fetal heart rate of 136 per minute without acceleration was only at 6:30, but at 7 a.m. it was with fetal deceleration. So going to the pathograph, to the labor care guide, and looking at the area where we're supposed to look at, these are the fetal heart rate parameters which are normal. The fetal heart rates, the deceleration was normal, none was flagged. But when it came to fetal position, because it was posterior, this was flagged. and there's a plan. So when we have a flagged input like this, the next thing is to refer to your labor ward protocol, the local protocol, or to refer to a senior person. The document does not prescribe what you should do. It allows you to use your experience and your local protocol to solve the problem. So that is one of the very important characteristics of this document. Section 4 is care of the woman, which is about the heart rate. So we have pulse rate of this range, 60 to 120 being considered normal. Systolic blood pressure, 80 to 140 is considered normal, to less than 140. And diastolic of less than 90 is considered normal. Temperature range up to 37.5 degrees centigrade. And protein and albumin in the urine of less than 2 pluses is considered, 2 pluses and below is considered normal. So here again, we have our Mary Jane. At 6, our pulse rate was 88 per minute. Blood pressure was 120/80. Temperature was at 6.5. And then at 10 a.m., it was, because this is 4 hours apart, 96, 124, and 39.C. How is this plotted on the document? So here we have it here. So the pulse rates, everything is considered normal, and this is how it's charted in the document. There's a place to chart it. It's not different from what we use in the pathograph, really, in this regard. So this is just to show that once, I just want to illustrate what I said earlier, that they allow you, if blood pressure is greater than 80 or less than 80 or greater than 180, alert a senior provider and follow local guidelines. That's very important. I need to highlight that this document allows you to, so this document actually encourages the development of local guidelines for the use. So completely page 5, this is from the table, plotting. I think examples illustrate this better. So let me go back to the example and illustrate it. So these are Mary Jane again, the same time, 6 a.m., 10 a.m., 1 p.m., and 1:30 p.m. So she had 3 contractions every 10 minutes, lasting 40 seconds. The baby is cephalic, and the fetal descent is 4/5. Then she moved from, she was how many cm here? She moved to 8 cm at 10 a.m. She was examined at 10 a.m. She was 8 cm dilated, and by 1 p.m. she was 10 cm dilated. How is this plotted on the document? So again, this is what we see. So she had 3 contractions per 10 minutes. This is written exactly as it is. Then the duration of contractions is written exactly as it is in terms of the figure, the number of seconds. And then remember, okay, so this is where the major thing is. If when she came in at 5 cm, you can't flag her as an alert except she stays at 5 cm for more than 6 hours. Luckily, this woman doesn't give us that dilemma. She moved on to 8 cm, which is allowed to stay for another 2.5 hours. But again, by the time she was examined later, she had moved to 10 cm. It's only at 10 cm that you can intervene if she's not making progress. So these are the ranges. So these are the normal, these are what's considered the new normal in terms of the labor care guide. There's no alert line, there's no action line. You just look at the normal. And until the woman has actually exhausted the number of hours she asked for that particular dilatation, you cannot consider it abnormal. Again, the sense is plotted as we used to. This is 4 feet palpable with an O. This is 3 feet palpable, and by the time she was fully dilated, she was 2 feet palpable. So these are the important landmarks for use by this document. So she has completed her labor, and I want to introduce another section of the care document. Sorry for that. This section, the plan section. So at every point in time, when of course this is the medication section, you just write the guidelines are there oxytocin, other medications, their doses, IV fluids, how many how many units, how many meals the woman has received. And then for assessment, when she had, if you look here, they said pain relief required. If you go up, you notice that at this point in time, she had no pain relief and she had no companion. She had no companion with her. So offer offer companionship, relaxation technique, which was because that's what she wanted for pain relief. So that's the plan. So you have the assessment and the plan section of the document, and of course, whoever is offering the assessment will put their initials in the document. So this is the this is the whole 7 section of the document, and now it should be filled. It's not very difficult to fill. It's not very difficult. These are things we already know. The other aspect is second stage of labor, which talks about let me highlight a few things there. Companionship is encouraged in labor, and she's not supposed to be supine. She's supposed to move until she's about to deliver, according to this document. This fetal heart rate, early deceleration was noted, number of contractions, the time, and when you also to record efforts in pushing. When did she start pushing? These are things that are documented in this document. They are clear. I'm skipping the tables. The tables describe clearly how this is supposed to be assessed. Remember, it is assess, record, check whether it's normal, and then plan. So you go through the 4 stages. So if you assess, there's a guideline on how to assess. There's guideline on how to record. There's also guideline and the check is there on the alert line, and then the plan is what you do based on your local protocol. So, what are the key points of this labor ward guide? 1, it puts positive pregnancy experience into action. Things like companionship, taking oral or taking fluids, allowing women to move around are things that we normally don't do. But this document, well, in its raw form, expects us to do that, and these are recommended. It is not a management tool for abnormal labor. Each facility still needs to develop their own protocol for management of abnormal labor. You cannot escape that. When you have an abnormal parameter, it doesn't prescribe, a few basic things that give oxygen and all that, but really the decision to take a section and all, and those other and those other advanced decisions are not prescribed in the document. It's something that we still use our clinical judgment to do. Major paradigm shifts that I see in this document is support in labor is encouraged. Oral fluid in labor is essential. Active phase of labor is redefined as 5 cm and above. And then cervical dilation is not 1 cm per hour. At 5 cm, a woman can actually stay for about 6 hours before this is done. And I see that this will require infrastructural support. Most labor wards that I know don't have space for people to be able to support them. They don't have cubicles that encourage people having social support. And I see this as a very important impediment to the implementation of this document in Nigeria. So I have a few suggestions on implementation. I'm sure there'll be a lot of discussion on this during this. I see that we have 99 chats already. So I'm sure there are comments about this already. I believe strongly that WHO should, the Ministry of Health should integrate this document into the various training manuals for healthcare workers. And the use for this document at the different levels of care should be well defined. I mean, even at tertiary level, so we're struggling to fill some of this, some of these things. I don't know how that will work at the primary healthcare centers. I don't know. Appropriate staffing of healthcare institutions is important, and training. Then professional institutions like AFEMSIN and SOGON, we need to organize training workshops, maybe in collaboration with JAPIGO and some other organizations, even WHO. And they're a good part of our pre-conference workshops. We do ultrasound, we do everything. We could also include this as part of the pre-conference workshops. And then institutions should develop protocols for labor ward care based on the recommendations from this guideline. For instance, what do we consider food? What do we consider fluid? All of this should be well defined in our own local protocols. So thank you for listening. And these are my references.
Fantastic. Thank you so much, Professor Olayemi. I'm sure everyone agrees that, for me anyway, I found that it's finally been simplified to a large extent, even though it's a complex document in terms of the fact that we have so many different parts of it. But the truth is that at least we know the salient parts, and we know now that this is something that we all have to go to our local environments to work on. We're close to 5 o'clock now, but I believe that I'm sure people would want to have an opportunity to ask questions. So we'll do it for about the next 15, maximum of 20 minutes. Now, what we're going to do is, please, I am a bit of a general when it comes to things like this. You have 1 minute or less to ask your question. If your question is beginning to be a comment, I'm going to, and the beauty of it is I'm the host and this is Zoom, so I will mute you. So please ask brief questions. I've seen some hands up, and I know that Iheke Ogbona has put his hand up since much earlier. So I'll give you the first point of response. So please go ahead. I will unmute you. Ogbona, you can ask your question, please. Or was your hand up? Does Iheke Ogbona want to ask a question, or did you just forget your hand up? I've tried to unmute you. I hope it's not that asked to unmute. It's not happening. I thought I was, hang on. Okay, can we try Maradona? Okay, I've seen, okay, I think I can unmute you now. That's not working, so let me move to Maradona. Dr. Adaramoye, what's going on? Why can't I unmute people?
Maybe while we're waiting to unmute them, there's some
there's some in the chat.
Yes, I have a scribe here who's been helping me with some of the questions in the scribe in the in the chat.
So please go ahead with that.
One of the questions is, the first and burning questions is, are we saying pantograph should be jettisoned? Well, I think that is obvious. If we are moving from one document to another, then pantograph should be jettisoned. However, I am aware that that's one of the concerns. But from what I presented, this is a much more encompassing document than the pantograph. It does a lot more than the pantograph, and it incorporates a lot of the new evidences and the recommendations. So if we're going to go forward, I think pantograph should be jettisoned. The other question I have here is the WHO New Labor Guide appears more expectant in management than active. Exactly. In fact, one of the recommendations in the guideline is that expectant active packages to make labor fast should be jettisoned. They should be discarded, that they have no evidence to support that they are useful. So definitely, yes, it looks like that, but it's not like that. It's like you allow women to fulfill we're not forcing them to dilate more than they should. We're using evidence that shows that if they don't dilate, nothing will happen. So why are we forcing them to dilate? What is the ultimate reason why we're increasing the rate of dilatation? Is it not because we think something bad will happen? But if nothing bad happens, so why are we doing that? And it's not even as cost effective as spending a lot of resources. And that's why a lot of them eventually have cesarean section. There's a protocol I read while preparing for this, of a study that's going to be done to prove that this labor guide will reduce the rate of cesarean section compared to the usual care. So when this evidence for this comes out, we're going to be seeing what we have. What of ARM at 6 cm? Absolutely not. That's one of the recommendations. Maybe I should go through the recommendations. That's one of the things that is not recommended. Having forcing and using artificial rupture of the membrane, unless it is medically indicated, unless there's a reason for doing it, it's not recommended anymore. Please, can labor guide be used for VBAC cases? Yes. Like I said, when you have high risk, you use additional recommendations, but it is in addition to this labor guide. You can still monitor them with labor guide, but then the actions you take will depend on your protocol based on your finding. For instance, if your protocol doesn't allow them to spend five hours in or 5 cm at your own center, or by you have scientific evidence for that, for VBAC, you can use that. If there are guidelines for VBAC that doesn't allow that, you can use that. But this document is still useful in monitoring. Is the execution that will differ, how you execute the findings that will differ in terms of that. So those are the questions I've been able to get. Okay, what is the rationale for using cervical dilation of at the active phase 5 cm? I provided evidence. Maybe I should go back and see whether I can show you the evidence for this. So cervical dilation of 5 cm. There's a chart. There's a study that was done that showed that women, the cervical dilatation at 5 cm was better. Well, that's the point at which actual is not this. Okay, this is the study. If you look at this graph, not very big, but I can expand it. You can see that there's actually a change at 5 cm. And this is one of the evidence. There are other evidence. This is the one I'm just presenting. If you search the internet, we'll find others. If you read the document itself, there are other evidence that's provided. I couldn't possibly give all the evidences. I just picked them. I picked the ones that I thought were relevant. But there's plenty of evidence that was considered for 5 cm, and it's there in the document itself. So definitely 5 cm, based on the evidence available, is the most appropriate time to start to calculate the active phase of labor.
Prof,
So
one question that has been quite prominent is the issue of augmentation, and how do you augment labor when indicated if ARM is guarded, and how do we, and the follow-up to that was, how do we navigate the theoretical risk of amniotic fluid embolism in these women? Over, please.
Thank you. I think that once you need to augment labor, that woman has moved away from the realm of the range of this labor guide, and you have moved to your own protocol, and you can do things based on your protocol. If your protocol or the evidence you have supports doing ARM before starting augmentation of labor, you can. But I think I read in the document that there's no evidence concerning that. I'm not sure of this, but you can check the document and see. I think even document says that when you're augmenting, there's a whole guideline on augmentation of labor. And I think I read that, and I think I don't see ARM being based on evidence, but we should work based on evidence. If the evidence supports using ARM, yes, do the ARM before augmentation of labor. But if evidence supports all the things we think, all our thoughts and our myths and imaginations that some things will happen may not be true based on evidence, and people will have done studies on this. I didn't expect this particular question, so I didn't actually look at the evidence. But in looking at the document, I stumbled reading the augmentation document, which I didn't really read much, except for the parts for the mobility and oral fluids. It looks like that was not encouraged in that document. So you can actually download the document on augmentation of labor, the guideline, and look through and see what it says concerning this. Then there's another one. Since we're using the labor guide at all levels, when do centers with no CS criteria refer to higher levels of care? That also is one of the points. But the honest truth is that just like the other labor guides, this labor guide contains molding, caput, contains cervical dilatation, however liberal it is. At the points when your decision when your plan is to do cesarean section, I think at that point can be referred. And this document also showed that there's a lot of leeway. So, well, there must be, those are the kind of things that we need to think about too. How to refer, when to refer. But as it is, even as it is, once the assessment is and the plan is looking like a cesarean section is necessary, like in obstructed labor where there's fetal heart rate abnormalities. Your decisions will decide, I mean, based on the decisions. And when there is no facility for cesarean section, this kind of woman should be referred immediately.
There's a question about any empirical evidence from local studies to show that the labor care guide is superior to the pathograph.
Yes. Sorry, may I hear that again? Sorry, can you repeat that, Prof?
Is there any empirical evidence from local studies to show that the labor care guide is superior to the pathograph?
Not yet. I alluded to a study that the protocol was published. I'm not sure they finished the study, where they're trying to see whether the labor guide compared to pathograph will reduce cesarean section rates. That is, I'm not sure it's a local study though. So these are research areas we can look into. In fact, I didn't go into that. There's a lot of research issues that were raised in the guideline, which you can read. And I'm sure this is one of them where we can actually compare the labor guide with pathograph under several respects. Well, I need to read this from my friend, Professor Andrea Oguze. Wonderful presentation, Prof. As usual, I've taken the scale out of LCG. I hope so. I hope I've taken the scale out of it. Thank you, sir. Thank you, ma'am. Is companionship, another question is companionship in labor recommended throughout labor or just an active phase? It is recommended throughout labor. If you look at the, let me again show the slide. I'm sorry, I'm going through this manually. If you look at the, I think it's probably my last slide. Let me see if I can get to that immediately. Maybe I should remove it from slideshow and yeah, this one. You can see that here in Bath, you can see that companionship was still expected. You can see that here in the second stage, if you look at companionship, yes, was still reaching there. The column still exists, the row still exists for companionship. So yes, companionship is expected in second stage of labor, according to this document. How would one estimate 5 steps like that? The same way we do clinically. The guide offers some advice, but the same way they can't tell us the basic of how to examine the cervix. So we just use our clinical acumen like we used to normally. It doesn't change that. That is our own clinical acumen.
Question, please, Prof. Where do we get the labor ward guide from? I need to tell people about that. And then
it is in the second document. It is actually the second document I presented.
I'm saying where can an individual?
It's online. It's online. You can download I downloaded it online. That's where I got my document from.
So we just go online to the
go online and download. Yes, you can even type it. User's manual for labor ward guide, and you get it and you download it. It's free.
Great.
The second document.
The other thing I was going to say was that somebody asked about African or local studies. That particular slide you're on showing the 5cm, the cohort study that was done. It was done in sub-Saharan Africa, 2 sub-Saharan African countries.
South Africa, yes.
South Africa and where?
Well, I think South Africa. Let me go there.
Please.
Is this one? No, I don't think so. No, it's not here. I'll find it. Actually, if you look here, you find very familiar names. Let me just start with her. There is
Oladapo, for example. I saw that.
Olayemi is there. So these are people that conduct study. Nigeria is one of the countries. I can't find. I have to look at the original document to find the other country, but definitely Nigeria. You can see Nigerian names.
I know someone called Maradona was trying to speak. I was trying to unmute you just now. Do you still want to speak? Let me just try and. Yes. Can you speak? I've asked to unmute you. Okay, your hand is not up anymore. Let me try. Umelo Ferdinand. Can you speak? Has it been? Yes. Umelo Ferdinand. Yes, go ahead.
Finally. Yeah, thank you, Prof. it was actually an interesting presentation. So I have this question. During your presentation, you said that a stagnation at 5 cm, for example, should not raise an undue alarm. It can stay up to 5 hours if I get it right, if I'm not mistaken. So my question is this: during the active phase of 5 cm and above, up until 10 cm, what would one consider a prolonged active phase? Because if the woman gets stuck at 5 and at 6 she's stuck, at 7 she's stuck, when should I be alarmed? When should I raise an alarm? Will I keep her at 5 cm at every stage? That's like 30 hours. Thank you, Prof.
Okay, thank you. I've unmuted. Let me go back to that guide. Thank you for the question. Hello. Hello.
I can hear you, Prof. Go ahead.
Okay. All right. Okay. So this is what the guide says.
Everyone else should please mute themselves. Thank you.
So this is 5 cm. It says 6 hours there. When a woman gets to 6 cm, she has 5 hours there. Now, a woman who is stagnating at every point, obviously there's a problem there. And you need to do something. You can't keep a woman in labor for 30 hours. Although technically, this guideline says you can, because once at every level, she doesn't exceed the number of hours she needs to she has there, it is considered normal. This is all part of the reasons why they're doing this document. I remember at the discussion of this evidence at the guideline development group, it was things like this were raised, and it looks that evidence is evidence. Well, even in the study that was done, somewhere were in labor for up to 30 hours, and nothing happened to them. That's the point.
As long as all the other parameters
are normal.
Yes, that's one thing that needs to be stressed.
So you're not looking at the adaptation in isolation. You're looking at every other parameter. That is the paradigm shift we have to accept.
Yeah, vital signs, the fetal vital signs as well. Everything.
The temperature, everything is normal. Yeah. So that is what this document is saying. So, I mean that's so I can't say beyond that. Well, somebody's asking how the derivation was arrived at. Is a synthesis of evidence. Some of the evidence.
So Yetunji was speaking. Sorry, what did you say, Prof. Olayemi?
Yes, there was something on the chat about how duration of each cervical dilation was arrived at. I provided some evidence, but it was
also, yeah.
But if you look at
research.
Yes, but if you look at the documents, the evidence is all the evidence where it is provided is there. You can read it, you can read through it, and you'll be convinced. I can only present a few of it, which is what I said. What I was my own aim was to show that 1 cm per hour is not useful. Now, the other aspect of it, how many hours for each cervical dilatation is provided in a document. There are studies that have been done to show this. Some of it done with Nigeria too. Like the one I cited.
The maximum what I'm going to do now, Prof, is to just let the remaining 5 people here ask their questions, and you please take note of them, and then we call it a day because we've gone far over time. So Dr. Oyetunji wanted to ask a question. Please ask a question, and Prof, please get somebody to note it down for you. Dr.
Yes, somebody's writing down, yes.
Okay, thank you, Prof. Is a comment I have. You have room to make comments?
As long as it's 1 minute, let's
go ahead.
Okay. So thanks so much for the presentation, Prof. Actually, it's an Herculean task that you have to do within such time. Just to inform us that currently, JPIGO with IHP, Integrated Health Program, we are field testing the modified labor care guide in Nigeria in 5 states and FCT, and in over 100 health facilities. And so far, the outcome has been very good. So the fear that labor care guide is difficult has been allayed, and we'll be sharing the evidence or the findings very soon, like Professor Etuk said. So it's currently in use in Nigeria in 5 states. Thank you, and over.
Thank you very much, Dr. Yetunji. Dr. Kore, quickly, please.
Thank you, Prof, for your presentation. My question here is that what has anything changed from the cervical dilatation of 1 cm per hour in a case where you are doing induction of labor or stimulation of labor? Then what about the special patients you need to monitor closely in labor? Unlike a normal routine patient that comes in labor, but there are some cases you need to monitor some patient closely. So what happened with the use of labor care guide? Thank you.
Thank you very much. Dr. Gbanulu, very quickly, please.
Okay, thank you, Prof. Thank you, Prof, for the lecture. So my question is actually on the implementation of this labor care guide. Bearing in mind the limitations that we have in our region, the need, obviously, we for us to use this document, we have to use it with local our own local guidelines as well. So making the paper more than one document and making it more cumbersome. And then there's need for retraining and retraining of even the staff before we can even, and even the nurses, to be able to even imbibe into this, to leave the old pathograph. And then how cost effective will it be? Bearing in mind our own this third world country, that our the resources are scarce in our healthcare centers, especially in the rural settings. So all these limitations.
Noted. Thank you, Dr. Gbanulu. Thank you. Your questions are noted. Thank you. Dr. Bangbokwa, next, please.
Thank you, dear Prof. My question is that in looking at all these evidences and the guidelines and all the studies that have been done, has there been any assessment of the demands on the health worker in terms of course, with all this extension in time and everything, that we will have to develop a different level of patience now to handle these cases? So is there any assessment of what this holds for us providers in terms of how we manage the time? Thank you.
Thank you. Thank you very much. That's quite a good question. And Dr. Sama Yusuf to end the questions. Thank you. Quickly, please.
Very much, Prof.
Breaking.
So my question is,
okay,
is there a consideration of pain management? Is there a consideration for pain management?
For
pain
what?
Is there a consideration for pain management for this
Thank
patient? If the
management
patient is advanced labor and we probably were not able to give epidural or all the other ones we could give, and we have to leave them till they eventually probably have the urge and not do anything active.
Thank you.
I think I will start with the last question.
Yes.
Is that the last question, Prof?
It is. It has to be. Thank you.
All right. So, consider for pain management, it is actually more robust than the other documents concerning pain management. You're allowed to use any form of pain management, including epidural. So there's nothing that is stopping you from using from using your usual pain management for this. Now I'll just go from below. Somebody asked on assessment of healthcare workers. There was a study which I actually did not quote. A lot of things materials I got, but we didn't include in this presentation. Acceptability of this document by healthcare workers is very high. They've done studies on that. Acceptability of, so I'm sure for them to accept it, it means that they did study in some countries. It's online. I mean, I don't know. Maybe there's an AFEMSIN group. Maybe I can share the document on the AFEMSIN group. So yes, there's demand, but they still, despite all the demand and all the work, the ultimate conclusion is that they found it acceptable. Cost effectiveness is not something we can talk about without studies. And since WHO has agreed that they're working on it, maybe we'll wait for their results. I'm sure cost effectiveness is probably what they're assessing, but that will take research. We can't just I don't know whether any research has been on cost effectiveness. The cost effectiveness of each of the recommendations have been done and they found it to be cost effective. But the use of local guide as a whole, I don't know whether any study has been done concerning that. Yes, I agree that implementation will require building local guidelines and training of staff, which is what I suggested to, which I think they're working on in the ministry. Maybe Professor Tuku will be able to talk about that. The committee he attended, I'm sure that it was part of, I'm sure training is part of what they're doing. And that is why I recommend that this should be put into the in-service training documents. The Ministry of Health has a lot of in-service training documents for different cadre of staff, doctors, nurses, and everybody. So this should be put there. Now, patients you monitor closely, do you use this guideline? I said this from the beginning and I repeat again, bears repetition, that this guideline is for everybody. But your care, when there's another risk, your decisions, your plan will depend on the condition you are managing. So if you are managing a woman closely, yes, you can use this guide, but the actions you take, the decisions you take, the plan you have is going to be different. It's going to be based on your protocol. So for every observation you get, if you need to change it, if you need to take an action, the assessment and your plan will depend on what you have in your protocol. So yes, you use guilty. But if in your clinical judgment, you think this document will restrict you, you can always use your clinical judgment. That is my own advice. And for induction of labor, there's a guideline on induction of labor that is quite clear. The guideline is available. I projected you can get it online from WHO. So it depends on, all the recommendations for induction of labor can still be followed in the context of this document. And again, if you think that you want to manage without the use of this document, it's fine. But the recommendation is that this document can be used even when you're performing induction of labor, because there's a place for oxytocin drops, everything is here, IV fluids. So definitely you can use it to monitor your patients on induction of labor. But the specific guidelines as to actual rupture of the membrane, all of those things are contained in another guideline, which is beyond the scope of this study, of this presentation. So you need to look at that presentation, those guidelines, and follow the guidelines, or you can look at evidence and form your own local guideline in your own institution. Thank you. Over and out.
Thank you very much, Prof. Olayemi, for this really great presentation. As it is, this is something that everyone still needs to download and read, but I think it's very positive. There's nothing new that doesn't come with worry about change and worry about how it could be implemented. But the good thing is that research has supported this. And it's one thing to say, oh, maybe they did research on other people, but they did use African women in part of the research. So I think that we should take note of the fact that all new things, there's always some difficulty with accepting it. And the bottom line here is just saying that once a woman is comfortable in labor, you don't have to rush her. I think that's one of the summaries of this whole presentation.
Yeah, it's a takeaway there. That's a good takeaway message.
Thank you very much. I'm sure there are millions of questions, but we don't have any more time. I just want Professor Etuk to speak again. And after that, we'll end the session, especially based on what you said about the committee that is looking at this. Thank you very much. Prof. Etuk. Thanks a lot, Professor Olayemi.
Thank you very much.
Thank you very much.
I'm honored,
the VP and the presenter. Thank you once again. I'm not surprised. I wouldn't have expected anything less. Thank you very much. I think the message again one wants to drop is that, like we had in pathograph, the one we are still using till date, which will soon be phased out. Labor care guide as it is meant for normal labor. Is meant for normal labor, just like we used in the case of a pathograph. And when there is a deviation from normal, and we follow the labor care guide, you see that they show you how to monitor the labor, an ability to detect that there's a deviation. Once there is a deviation, your normal way of management of that deviation will take effect. So we shouldn't have impression, like from the questions asked, we shouldn't have impression as if once a woman is there, no matter what happens, you will allow the woman to continue. It doesn't continue like that. You monitor the woman globally, fully, and make sure that every parameter is in order. then you leave the woman. Once there's a deviation, the management should be instituted as demanded by your protocol. So once again, I thank everybody for this. This is something I believe should be repeated and repeated and repeated, because it may take some time for us to actually accept it as it is. You know, one of the most difficult things to do is to accept a change. But as it is now, this change is to the positive side, and we should all make effort to adopt. I want to thank everybody that has made effort to be here, and I challenge us to look at it again and again on your own. Download the necessary document and look at it. With time, you'll be able to appreciate and probably become a champion on it. Once again, thank you very much. Thank you, the presenter. You are great. My VP1, you are wonderful. All the ESCO members, all the members of FMC, all those who have witnessed, without you, it wouldn't be the way it is. So I'm grateful. Thank you, and God bless all of us.
Amen.
Thank you very much, sir. And I want to thank the other members of the academic committee of AFEMSIN, because we all put this together. Thank you very much for doing this. And Professor Olayemi, thanks enough again. In 3 months' time, we'll be coming up with another interesting webinar. This has been the best till date. We had over 400 people at the during this, about 420 people on this webinar. I don't think we've had any other webinar that has been this well attended. We thank everyone. It's obviously an interesting topic, and we'll come back to you with another one very soon. Thank you very much again, and God bless everyone. Have a good evening. Thank you.